I welcome you all for this CGR and topic. What we have chosen today is voice disorder. Uh, the reason of choosing this topic was nowadays, because of the advances in technology and all, as well as the stress, daily stress in the life, and the voice as a professional, and otherwise also we human depend on the voice to communicate. It become important. So we will discussing about the voice disorder. Uh, I will invite Dr. Arvind to start it. Thank you, sir. Good good afternoon, everyone. Today's grand clinical grand rounds is about voice disorders. Human rely on different ways of communication, which are linguistic and non-linguistic. Among the linguistic, we have verbal and non-verbal communication. Today, we are going to discuss a small subset of verbal communication disorder, which is voice disorder. Why the patient coming to our voice clinic usually have hoarseness or dysphonia. Hoarseness is abnormal quality of voice which may be rough, hoarse, breathy, weak or strained. Whereas dysphonia is whenever patient says that his voice is not as per as what he perceive it is. Even when our machine was having a voice disorder. So dysphonia is whenever patient think that patient is having a change in voice, even if other do not perceive it as different or divergent. Whenever patient think that he is having dysphonia, then it means patient is having dysphonia. Uh, it, Laryngeal evaluation has changed dramatically over past century. You can appreciate the change in the technology on the camera. You can appreciate the change in the light source technology. We started with the limelight. Now we are having LED light as small as sand grain. So our visualization has improved from IL mirror to now we are having flexible and rigid endoscopes, which much more better quality of vision. Voice disorder, whenever patient comes to us, we have to evaluate voice quality, pitch and loudness, and all these things depends on the patient age, gender, cultural background also. Like voice is produced with the power of lungs, and resonation occurs in the vocal cord, and this voice which is generated are in harmonics and sub these harmonics are modulated into different consonant by upper airway. During phonation, the larynx is stabilized with external laryngeal muscles. As you can appreciate the different vector in which the muscle pulls, and vocal fold is tense with help of these intrinsic muscles. These intrinsic muscle cause change in the tension in the vocal cord, as you can appreciate. Now, with increase in the length of the vocal cord, pitch also increases. And whenever this voice is generated, actually what is happening, mucosal this mucosal fold over the muscularis layer uh, is vibrating. This larynx, oropharynx, oral cavity, and the nasal cavity works in synchrony to produce individualized speech in the patient. Now I call upon Dr. Tony Manoj, for sharing his experience in the voice clinic.
So in voice clinic, we mainly deal with the patient with the voice disorders, which can be broadly classified into the functional disorders or disorders due to the phonotrauma and psychogenic disorder and the neurological disorders. So how do we process these patients? So patient come to our regular clinical OPD, ENT OPDs, and because the OPD we have limited time, so we cannot evaluate and patient for the voice disorders. So we refer them for this voice clinic, which is in Monday at 3 p.m. it occurs, and these patients get registered there. And how do we assess? Is first we take, there is a particular format for these in which it started with the clinical history, detailed history, and these are the patient related indexes, reflex simpler index and the voice handicap index, in which they tell that how much handicap they feel because of these voice disorders. And our speech language pathologist, they do the voice analysis with maximum phonation time. It's been recorded for all the patients, and the examination is done by our consultants in form of video laryngoscopy followed by the stroboscopy, in which we see the detailed vibration patterns which has been already described in detail, and we diagnose the patients. After diagnosis, we offer the patient these following treatments. Initially, it started with the speech therapy, which can be offered to the all mostly all the patients, and few patients are provided medical management, and the patients who are not getting benefited with the speech therapy or medical management, surgical intervention also being offered. These are the current stats of the patients which have been included post-COVID since January 2020. And we had 79 females and 124 males, mostly in the middle-aged population. And these are the diagnoses we have made. So most commonly, patient came to the voice clinic with the laryngopharyngeal reflux changes, followed by TVC polyp, then the pseudosulcus, and in decreasing trend, we had many patients with the bilateral TVC palsy and left TVC palsy. Then few patients we had of adductor spasmodic dysphonia, stress-associated dysphonias, functional dysphonias, and functional aphonia also. And many of the patients were having TVC cyst, and few patients had laryngoceles and TVC keratosis. And these patients were offered following treatment. Most commonly, these were managed conservatively with speech therapy and the medications. And the patient did not improve on the speech therapy, or they have been mainly offered the microlaryngeal surgery, which is a broad term, and in many surgeries come in this. And few patients underwent the thyroplasties like type 1, type 2, and type 4 thyroplasty, and in injection laryngoplasties, and which will be discussed further. So hereupon I called Dr. Arvind to discuss how do we process and work up these patients.
Thank you, Manoj. When patient come to us in voice clinic, what we evaluate is demographic profile of the patient, like gender. We all know that the larynx size and shape changes with the age. With the age, under the influence of androgen, patient's larynx, the size of male larynx grows around 50% more than the female's larynx. With the patient, wherever they are living, like patient living in the Ladakh area, they are living in a very dry environment. This dryness can cause crusting in the larynx, which can alter his voice. Patient who are having hobbies of different kind of hobbies, like this patient is having smoking habit. Because of this his smoking habit, you can appreciate laryngeal edema. This edema is known as Rinke's edema. Smoking can also lead to malignancy. That, like this patient is having vocal cord malignancy, leading to altered voice. History of Past history is also important. Like this patient is known case of Parkinson disease. You can appreciate tremor in the arytenoid right now. Patients having voice disorder secondary to the change in this tremor in the vocal fold. History of medication is also important. Like this patient had Steven Johnson syndrome, leading to scarring in the larynx. His intubation history leading to scarring in the posterior commissure area. History of recurrent papillomatosis leading to recurrent surgery, and now patient again coming with the same complaint of recurrent laryngeal papillomatosis. Profession is also important. Like this patient is known PT instructor. Because of his voice abuse, he is having vascular ectasia of the vocal cord right side. Whenever patient come to us after endoscopy and rigid, which is either can be rigid or flexible, we can also do stroboscopy. We have different kind of scale to evaluate handicap index and reflex related index. We have perceptual evaluation also, which is done by our speech and language pathologist. Acoustic measures are also can be done. These are also done by the speech and language pathologist. Electromyography will be dealt by Dr. Suchita. Why we need stroboscopy? Because vocal fold vibrates for around 150 times per second, and this final movement can't be appreciated with the laryngoscope. We have to slow down the speed of vocal fold movement so that we can appreciate the change in the vocal fold vibration. This is the stroboscopy machine we have. We have to place a mic over the larynx to pick up the frequency at which it is vibrating, and this sound is transmitted to this machine, which is a stroboscope. It throws flickers of light at the same frequency at which vocal folds are vibrating, so that The principle remain the same. Like in this picture, the frame rate of picture is same as the vibration of the rotation of this helicopter. Similarly, when the light flicker is having same frequency as the frequency of vibration, then we will see stationary. When slight change in the frequency is there of the flicker of light, we will have slow motion effect. This is how we do stroboscopy in our OPD, and this help in distinguishing the wave from the, like, this patient is having some hyperkeratotic area. To check whether this is infiltrating inside the muscle, we can appreciate the mucosal wave in this patient. This means that this lesion is very superficial, it's not going deep, it's not an infiltrating disease. We can also appreciate different kind of glottic gap during the phonatory cycle. As you can appreciate, this is the fusiform glottic gap with the stroboscope. This is also a fusiform defect with the stroboscope. This is hourglass glottic gap. This is posterior commissure glottic gap. With the endoscopy, we can also evaluate effect of acid on our larynx. You can appreciate the changes because of this acid reflex can lead to subglottic edema, ventricular obliteration, erythema of the posterior, especially the posterior larynx, vocal fold edema, diffuse laryngeal edema, posterior commissure hypertrophy, granulomas, and thick endolaryngeal mucus. And we can score these things, and this score quite well correlate with the pH documented reflux. Now I call upon Dr. Himanshi Sharma, who is a speech and language pathologist in our department.
Good evening, everyone. So we as speech language pathologists deal with a range of speech and language disorders, ranging from articulation disorders, including speech sound disorders, phonological disorders, fluency disorders, including cluttering, stuttering, and language disorders like child language disorders like delayed speech and language, mental retardation, autism, and voice. In today's presentation, I will be focusing more on voice disorders. So voice can be judged based on these three parameters, which are quality, pitch, and loudness. Quality is how this voice is actually sounding like. Pitch is the psychoacoustical correlate of frequency, and loudness is the psychoacoustical correlate of intensity. So a voice disorder occurs when voice quality, pitch, and loudness differ or are inappropriate for an individual's sex, gender, cultural background, etc. So we begin with our evaluation after the referral. First of all, we undergo a familiarization and rapport building process. After that is done, we probe into case history. We probe into the nature, onset, course of the illness, associated factors like throat pain, any foreign body sensation or fatigue. We need to look into other comorbidities that the patient might be presenting with. Personal history includes the patient's profession, his social status, and and if there is any history of substance abuse. After the history taking, we move on to speech mechanism examination, in which we do a detailed oroperipheral mechanism examination. Lips, jaw, palate, teeth, tongue structure and function are all examined. And also we look out for any signs of neck muscle tension, etc. Perceptual voice evaluation is then done, which is solely done by listening. Speech sample is collected and through reading, connected speech, while prolongation, cough, and in children, we might observe their vocal behaviors during play activities as well. So to evaluate pitch, we have to look for if there is any pitch breaks, pitch tremors, a reduced range of pitch, whether it is inappropriately high or low for the age or gender. For loudness also, we also have to look for any loudness variability, variation, reduced range. What is the habitual loudness, whether it is very loud or whether it is very soft. Quality is judged whether it is very breathy, harsh, or hoarse. Respiratory support. So to evaluate respiratory support, we need to look for the maximum phonation duration. So for a normal adult, it should be greater than 15 seconds. If it is less than 15 seconds, it is considered inadequate. Then we evaluate SIR-ZER ratio. SIR is a voiceless consonant while ZER is voiced. So the duration ratio should be equal to 1 in normal individuals. And if there is any deviation, then we can suspect abnormality. Then for formal perceptual evaluation, we administer these scales. Garbas and Cape P scales are popularly used. In Garbas, grade, roughness, breathiness, asthenicity, and strain are rated on a 4-point scale. In Cape V, it is a visual analog scale of 100 millimeters, and overall severity, roughness, breathiness, strain, pitch, and loudness are the parameters that are evaluated. Reflux symptom index includes 9 items and are rated on a 6-point ordinal scale. Voice handicap index also is rated on a 5-point ordinal scale and has subsections of functional, emotional, and physical. These are the pictures of the scales that I just discussed for your reference. This is Garbas, this is Cape V, this is reflux symptoms index, and this is voice handicap index. So after the formal tools, we go for objective voice evaluation, which starts with laryngoscopy, which has been discussed in detail by Dr. Arvind. And then we move on to acoustic analysis. Here in our voice clinic, we do an MDVP analysis, which is a module of computerized speech lab. This is how the software looks like. So once the voice is recorded, this is a radial graph that is shown. So these are the frequency perturbation measures. These are the amplitude perturbation measures. These are the noise related parameters. These are the tremor parameters, and these are subharmonic or voice break parameters. So the green circle that we can see is the normal range of all the parameters. The olive green shows the speaker's parameters which are inside the normal range, and the red shows the abnormal parameters that are deviated. So this is a sample of, it's not showing. So this is the sample of a normal voice. This is how a normal voice should sound like, and this is the normal MDVP report. So all the olive green parameters are inside the green circle. Now this is a patient with right TVC, right true vocal cord polyp. The voice is hoarse, and all the parameters are also outside the normal range. Most of the parameters. This is another patient with muscle tension dysphonia. This is the voice. We can appreciate the strain in the voice quality after humming exercise and other exercises were done. This is what this voice quality sounded like, which is better. There are some parameters which are still outside the normal range, but we'll be able to reduce. So this is another patient with right TVC palsy. So the patient has mild breathiness and reduced loudness. With therapy, this is the patient's voice, and we can and there's the improvement in MDVP graph is also evident. So these were the patients with organic lesions or organic causes of dysphonia. This is another patient with functional dysphonia. So the organic cause of voice disorder was ruled out first, and then the speech evaluation began. So the patient
गिनती करके दिखाओ एक बार
is unable to phonate, and with therapy,
1 2 3 4 5 6 7 8 9 11 12
this is what we could achieve. So functional dysphonia can also be presented in children. This is what the child presented with, and after therapy, this is what we could achieve. The stress factor identified in this child was upcoming exams, and the last patient reports it was financial stress post lockdown. This is another patient with puberphonia. So puberphonia, also known as mutational falsetto. So we can.
मेरा नाम विवेक है, मैं कानपुर में रहता हूँ, अभी 12th क्लास में हूँ।
This is a male patient, and we can hear that the pitch of the patient is inappropriately high for his gender.
मेरा नाम विवेक है। मैं 12th क्लास में पढ़ता हूँ।
This is the low pitch
मैं अटल
achieved with
आदर्श में
speech
हूँ अभी
therapy.
और
We
एम्स
can see in this picture also that the patient is compressing his laryngeal area, which is also known as Gutzman technique. So to release all the tension and to decrease the length of the cords. This is a patient with muscle tension dysphonia. We can see that the laryngeal muscle strain is quite evident in this patient, and which is all gone post therapy with humming exercise and all other relaxation exercises. So that was about the voice disorders. Misarticulation is also very common in our speech therapy OPDs.
Kaka, da.
So this child is actually substituting all the velar sounds with dental sounds. He's saying he's substituting k with t,
Ka, da.
and this is post therapy.
Kata, ka, da. Kaka, da. Ka. अब बोलो का.
So we could make him elicit k sound with appropriate place and manner education. So this is a post-stroke case with Broca's aphasia. So this patient presented with typical symptoms of Broca's aphasia with profound impairment in naming, repetition, and non-fluent speech. So there was difficulty in naming most common of the objects like phone and a flower.
Fu,
And the comprehension compared to that was fairly well preserved. She's able to do that very quickly. So we initiated with a melodic intonation therapy, which is based on the principle that the right hemisphere is preserved. Please excuse my singing.
गम से बेगाना होता है. अब इधर से देखो. मेरा नाम ऐसे गाना है. मेरा नाम मीना है. मैं 51 की हूँ.
So for a patient who wasn't unable to name common objects, she in the first session itself said this phrase, "Mera naam Meena hai," with melodic intonation. So till now we saw the success with speech therapy, but there are some cases where the success with speech therapy is limited, like this patient with the spasmodic adductor spasmodic dysphonia.
Students studying abroad.
So this is the voice quality, very strained staccato voice quality even after speech therapy. So in our voice clinic, in an office-based procedure, we injected him with Botox injection, and immediately after that his voice quality improved.
I belongs to Kekda Bagpat, Uttar Pradesh, or 51, 52, 53, 54.
This was done by Dr. Arvind. Thank you.
55, 56, 57.
Thank you, Himani. Many times it happens that even with the best speech therapist and best effort, patient doesn't improve with the speech therapy. And for such condition, what happens that patient thinks that the treatment he is receiving is not appropriate. So he keep on doctor shopping, like this patient. He went to some other doctor and who misdiagnosed this patient and injected him with Botox.
6 तारीख को इंजेक्शन लगवाया था बोटॉक्स, लेकिन मुझे रिलीफ नहीं मिला.
What happened is actually this patient is having severe form of muscle tension dysphonia. This can happen as a primary muscle tension dysphonia, or it can happen secondary to the other causes of voice disorders, which is known as secondary muscle tension dysphonia. And this requires extensive involvement of speech therapists. And when in our country it happens that we don't have enough speech and language pathologists, we have hardly 5,000 speech and language pathologists. To overcome this, we have designed one instrument with the help of IIT colleagues, Dr. Deepak Joshi, and it was the MIT thesis for Ashok Dan. What happens that whenever we are using excessive or this intrinsic and extrinsic of muscle, it leads to some change in the muscle tension, which leads to this muscle tension dysphonia. We can calculate this muscle tension dysphonia using deep learning methods, and we use there are different kind of deep learning methods, and this is what we use GRU, which is gated recurrent uh, unit. With this machine, we are able to approach this accuracy of 85% and precision of 87.8%. Recall is also 96%. So it was quite success in 40 of this patient. We are now we are in trying to develop it further. When patient doesn't have any lesion which can be helped with the speech language pathologist, like patient is having some structural defect which requires surgical intervention, we do surgical intervention in our general anesthesia OT, and this is the laser which we use for doing many of our laser laryngeal pathologies. This is the micro manipulator which can get attached to the microscope, and with this microscope and this micro manipulator, we can aim our laser beam after focusing that laser beam to an appropriate distance. We do this surgery transorally. So this is known as transoral laser surgery. The distance between this microscope and the lesion is around 300 millimeters, and the point where I'm putting this needle is actually the level where the vocal fold is. Example of how we can use laser is anti-commissure should be like this, but you can appreciate there is anti-glottic web. With the help of laser, we can ablate it very with precision and in a bloodless field. You can appreciate clear, precise incisions with the laser. This is carbon dioxide laser. You can appreciate gush of this smoke when this glottis has opened. Now I call upon Dr. Suchita to discuss his experience, her experience regarding sulcus vocalis.
Thank you, Dr. Arvind. Well, moving forward, as we move ahead with the next spectrum of patients that we see in our voice clinic, the next is the next is sulcus vocalis that are generally seen in our OPD. The patients come to us with hoarseness, and as we can see over here on a fiber optic laryngoscopic evaluation, we can see this scar that is present on either side of the vocal fold. This is the scar that is seen. Although it's not very well appreciated on a fiber optic laryngoscopic evaluation, that is more nicely seen or diagnosed in stroboscopy. Sulcus vocalis can be of two types. Type 1, which is physiological, which is an incidental finding, and the patient does not generally come to us with any appreciable voice change, whereas in type 2A and type 2B, the patient has a perceived hoarseness or dysphonia, as Dr. Arvind has already told you. So in type A, it's a sulcus vergiture, which is an atrophic epithelium. So we can appreciate that's just a small this is the small scarring that is present, whereas a type 2B, also known as a sulcus vocalis proper, or an open cyst, which has a thickened epithelium and is a more bigger form or a severe form of a sulcus vocalis. So this is the stroboscopic evaluation, and we can see the mucosal waves which are hampered. So these patients, after giving a proper speech therapy, they are planned for, if they do not improve with speech therapy, like the dictum was, the treatment for sulcus vocalis is speech therapy, and speech therapy. So only for the cases who are totally resistant and recalcitrant to speech therapy are taken up for any surgical intervention. The surgical intervention can vary in the form of fat injection to fat implantation to excision of the sulcus and grafting. What we are showing over here is a fat implantation. So the fat is usually harvested from the abdomen, and make sure that the fat that you have harvested has bigger fat globules and not a minced fat, otherwise it will be reabsorbed very quickly. So after doing a hydrodissection and making an incision, raising a flap, the fat globules are deposited in the space between the epithelium and the ligament. After that, the glue is applied. This is an immediate 1-day post-op status, and this is the 3-month post-op status. And on stroboscopy, you can see very well the mucosal waves that have come back. And again, that was a perceptual and an objective evaluation, which shows the change from the red graph to a green graph, showing that yes, not just subjective, but even an objective improvement in the patient's voice. This is a case of androphonia. That means it's a female who came to us with a voice of a very low pitch, that means a male voice. And what we did was a Wendler's glottoplasty. That means we freshened the margins, the middlemost margin of the bilateral vocal cords, and tried to decrease the length of the vibratory portion of the vocal folds by applying sutures. This is the post-op status. So can very well appreciate the difference between the pre-op and the post-op vocal parameters. Moving ahead, the other spectrum which we generally see in a voice clinic is a unilateral vocal cord palsy. Again, can be either a low vocal cord palsy or a high recurrent laryngeal nerve palsy, as we can see over here. A low vocal cord, a lower recurrent laryngeal nerve palsy, where the patient will present to us with hoarseness, never rarely with features of aspiration. So on evaluation, we can see the bowing of the cord and a glottic gap. So the patient will have a breathy voice where he is not able to vocalize very properly, and the patient will complain of escape of air while he is vocalizing. Whereas in cases of a very high vagal nerve palsy, the patient can also present to us apart from just hoarseness with other features of dysphagia also. And we can very well appreciate over here, there is pooling of secretions, there is bowing of the cord, and both the cords are also at different levels rather than at the same level. So now in such cases, we also take use of another armamentarium that is present in our voice clinic, that is a laryngeal EMG. So it's an electrophysiological investigation of a neuromuscular function, and the main indication, rather than using it for a vocal cord palsy, it is used for cases which is having a hampered vocal cord movements. So in cases of vocal cord disorders, especially in cases of reduced mobility. So it's a specific test to assess the nerve signals in a particular muscle, whether they are normal, abnormal, below normal, or hyperactive. These are the needle electrodes that are inserted in the particular muscle. It can either be a thyroid or a cricothyroid muscle, depending on what specific group of muscles we need to test. Then after inserting, and this is done in an OPD-based procedure on an office basis rather than under any general anesthesia. And after inserting the needle in whichever particular group of muscle you need to check, these are the graphical representation of the wave patterns. Moving ahead, in cases of unilateral vocal cord palsies, we have different approaches through which we can augment. It can be either through a percutaneous route per oral or through a transnasal endoscopic approaches. The most commonly applied are the percutaneous. So we go in with either, in this case, as you can see, it is a transcricothyroid. This will be a thyroid route, and this is a transthyroid route. These are the injectate or the injectable material that we use. We can use from calcium hydroxyapatite to fat to hyaluronic acid. We over here, for logistic reasons, these are the most commonly available. So we use hyaluronic acid in the strength of around 23 to 24 milligram per ml, and with, of course, some lignocaine present with it. Just a small video of an injection laryngoplasty. It is done again in an OPD-based procedure. So the patient is locally anesthetized with a laryngeal gargle and a spray, And the most common approach that we apply over here is a transcricothyroid approach, but all the three approaches are very well advocated. So over here we can see the needle appearing in the subglottis just below the level of the vocal fold, and we can see the needle hub and the injectate being infiltrated as we see the muscle mass of the left vocal cord increasing. So when we talk about the injection laryngoplasties, it is generally done at a multi-level method. That means 3 injections should be done. Mostly the posterior most glottis cannot be taken care of with an injection laryngoplasty. This is an immediate, and this is after 3 months of an injection laryngoplasty, where we can say complete glottic closure and very nice waves that can be appreciated in the post-op status. This is the preoperative voice, and this is the postoperative voice after 3 months of injection laryngoplasty. Now I would want to call Dr. Smita for the radiological evaluation.
Thank you, Dr. Shuchita. So basically for the radiological approach to vocal cord palsy, so a brief about the imaging anatomy. So whenever a patient is presenting with vocal cord palsy, the diagnosis has already been made and we are trying to find out the etiological cause. So the role of imaging is whether the cause is lying in the brain, the brainstem or the skull base, or whether it is along the course of the nerves. So we need to identify that in the region of the medulla, we would have the olivary sulcus and the origin of the vagus nerve. So this is the cisternal segment of the vagal nerve, the olivary sulcus, and then as it is going into the jugular foramen. So this is the area where there can either be an infarct, or there can be demyelination, or there can be a tumor. After exiting from the jugular foramen, then they would be traveling along the carotid nerve sheath. So the along the carotid sheath, along this course, there can be any pathology. Then on the right side, the right rectolaryngel nerve would be going caudal to the subclavian artery. So this is the arch of aorta. This is the origin of the vessels. So caudal to this would be the right rectolaryngel nerve, whereas on the left side, it would be below the aortic arch towards the left tracheoesophageal groove. So a longer course of the left sided, and the left side, the causes are found more commonly on the left side as compared to the right side. So the imaging approach is such that primarily the main working horse is the CT. So it is a contrast enhanced CT, which is from the skull base to the aortic arch, including the AP window, because it is many a times at the nodes or the lesions at the AP window which are causing the rectolaryngel nerve palsy. So if it is a unilateral palsy, which is most of the times, or it is an insidious onset, so what are we trying to evaluate? We are trying to evaluate lesions in the cervical portion. So it is the extracranial vagal nerve or the recurrent laryngeal nerve. And so for this, the main investigation of choice is the CCT skull base. And that is to be acquired in the quiet breathing. And most of the centers now have a multi-slice CT. So it is an axial acquisition followed by a coronal and a sagittal reformatted images of the CT. The common etiology is that either it can be an infection, benign masses, or malignancies, especially CA lung, which can have AP window nodes, or tuberculosis, which is having nodes in that location, nodes which the patient previously had, and now there is fibrosis. So it is a fibrosing mediastinitis, which is the cause of the palsy. Whereas in terms of a bilateral palsy, when we are thinking that yes, the lesion might be in the brain, so it is the brainstem that we are trying to evaluate. So the main investigation would be an MRI brain along with the 3D heavily T2 weighted images. So this 3D heavily T2 weighted images are different sequences like CIS, DRIVE or Fiesta. So which we commonly see when we are trying to evaluate the patients of cochlear implant it is the same sequence where we are trying to evaluate the 7th, 8th nerve. So here we are trying to evaluate the vagus nerve by this sequence. Apart from that, the post-gadolinium acquisition and the diffusion weighted images are essential to make a diagnosis between tumor and infections. So again, the etiologies, as we all know, infarct, demyelination, tumors or neuritis or skull base osteomyelitis. So these are the CT signs of vocal cord palsy. These are more for identification because patient when comes to us, we already know the patient has a vocal cord palsy. So this is more from theoretical. We are not really primarily trying to diagnose the patient has a vocal cord palsy. We are trying to do the CT to identify a cause for that vocal cord palsy. So the signs are like there is a widening of the laryngeal ventricle, or there is the Sale sign, there is a thickening and deviation of the arabic-glottic fold, there is a dilatation of the piriform sinus. So these are the so-called direct signs of a vocal cord palsy. So the central causes, for example, we can see there is an infarct. This is a diffusion weighted image where the infarct is bright on the diffusion weighted image. These are the different patients. Okay, sorry, the diagnosis has somehow disappeared, but this is a well-defined enhancing lesion in the jugular foramen, and this is glomus jugulare permeative lytic destruction, which is characteristic of the glomus jugulare. This is a case of skull base osteomyelitis where we can see that there are bony erosions which are along the pars nervosa of the jugular foramen, and this is the T2 weighted image where we can see that there is hyperintensity which is involving almost the entire central skull base. These are the extracranial causes. So we can see that this patient has necrotic nodes in the supraclavicular fossa, also in the characteristic location AP window. So this patient had a left-sided palsy. This is a case where there is mass forming soft tissue density which is encasing the vessels. This is a case of fibrosing mediastinitis. Another case where there were previously nodes in the AP window and now it has healed by fibrosis, but now the nerve has got entrapped in the fibrosis, so it is causing a palsy. Another patient with a well-defined nodule with CT guided FNAC is being done from it, and this turned out to be a CL lung, and there were prevascular nodes which were the cause of the palsy. Thank you. I would like to invite Dr. Arvind for the.
Thank you, ma'am. After seeing unilateral vocal cord palsy, now we are discussing something which will not impair patient's voice. But what will happen when patient is having bilateral abductor cord palsy? This is the different scenario. Patient present to us with stridor. This is how it sounds like. What is happening when patient is breathing in, vocal cord get adducted because of Bernoulli phenomena, and when a patient is expirating out, then there is some glottic gap between which air can escape. And as you can all see, vocal in adult larynx, the best space for breathing is between the narrowest area in the airway is laryngeal inlet, and in laryngeal inlet between the arytenoid area we have the largest space. That's why it's known as respiratory glottis. When these patients are having vocal cord palsy, this means that bilateral abductor cord palsy, this means that their the respiratory glottis is getting compromised. So what we do in this patient, in this scenario, we remove part of arytenoid so that the posterior chink can be increased, and this is how patient before, like this is a representative photograph. You can appreciate there's paradoxical moment. A patient can adduct the cord, there's no abduction, and there's no gap between the posterior aspect of the larynx. And when we remove the arytenoid, what we can achieve is chink in the posterior aspect, and this is adequate for breathing for normal purpose. And by doing these kind of surgery, we can preserve the mucosal membrane and the membranous part of the true vocal cord, which is responsible for the voice creation. These are the example of patient's voice after these kind of surgery in which arytenoid has been part of arytenoid has been removed.
नाम बहुरन सिंह का नाम रामलाल सिंह निवासी।
ऑपरेशन कब हुआ था आपका?
आप ऑपरेशन हुआ था 2 फरवरी 19 में।
छाती का दिल का ऑपरेशन?
जी सर।
अच्छा, ठीक है। This patient underwent cardiac surgery, after which patient developed bilateral recurrent laryngeal palsy. ऑपरेशन हुआ था?
जी सर, ये गले का। हाँ सर।
ठीक है। अभी ये ढक्कन आपका 5 घंटे से बंद है?
ये 5 घंटे से साफ बंद है अभी।
घुटन तो नहीं हो रही ना? He is able to tolerate the corking of tracheostomy tube, and phonation is quite appreciable. He can talk on phone.
9 10
सांस लंबी. And this is in pediatric, same thing in pediatric age group. You can appreciate the suture tracheostomy site. In patients who are not having any larynx after the surgery, you can see many of patients having laryngeal carcinoma underwent laryngectomy, in laryngectomy, what we do is we remove whole of the larynx, and after this removal of larynx, patient don't have any larynx. Even without larynx, patient can phonate. This is example of that way by which they can phonate. This is the tracheoesophageal puncture, in which tracheoesophageal prosthesis has been placed, and this is how they can phonate.
अच्छा, ऑपरेशन करे कितना दिन हो गए?
2 महीने 8 दिन हो गए, 2 महीने 8 दिन।
ऑपरेशन को या फिर ये जो ट्यूब लगी है?
ट्यूब लगी है, 2 महीने 8 दिन हो गए।
अच्छा।
Now I call upon Dr. Professor Rakesh Kumar for his concluding remarks.
So, basically, if you see, we have started from the area when we were PGs in early 90s. So that time it was mostly assessment under general anesthesia and remove polyp or inject the vocal cord, paralyzed vocal cord anesthesia. Now quite significant number of cases can be managed on the OPD basis under local anesthesia. And there are a lot more advances in technological point of view which can give you the diagnosis. However, the mainstay of the treatment still remain the speech therapy and the vocal hygiene. What we usually say that drink lot of water, so keep yourself hydrated, voice rest, don't speak unnecessarily, breathing exercises, humming exercises, and they can say om prolonged way, and healthy diet. That means the caffeine and junk food, skipping meals has to be avoided, and don't shout. So yelling and whispering is absolute no. Caffeine product like the tea, coffee, cold drink should be avoided. And if you have to speak longer, like the teachers or the lawyers, then they have to avoid that, give breaks, and maybe speak in a normal volume. Don't strain your voice. And this is what we usually give to the patient, the vocal hygiene performer, telling the same. And now I open this for question. Any question or comments are welcome. So this is in Hindi as well as English. So whatever patient choice, they can take it and read it. So one of the important aspect is psychogenic, cause I remember when we were PGs, the patient will come, sudden loss of voice. So we take their opinion. So what is to be done, and then the speech pathologist help, and all of a sudden patient starts speaking. So that those are hysterical kind of voice loss. So then Mr. Vijay was there, so I also learned what is to be done. The thing is, you ask them to, they will say, I can't speak. So, but you can cough it. Once they cough, see the voice is there. Now you can speak, or you tickle the larynx. Take your laryngeal mirror and go inside. Patient will gag and patient will cough. So that was a very simple trick. Otherwise, patient will have the loss of voice for 2, 3, 5 days. Dr. Rohit, you want to comment on that?
A lot to do. I had been missing that in my MBBS years. One thing just wanted to ask, like we, as you sir rightly said, for functional dysphonias which are referred to us, we just ask them whether you are able to cough or not, or we make them cough to get an objective assessment whether or not this individual is having functional or a structural kind of a lesion which might be there, a psychogenic versus structural lesion. Are there any objective evidences which could say that there is a structural lesion which could still be not functional, the psychogenic in that sense? So what is the rate of objective kind of elements being persisting, even though it might be a psychogenic, the false positive kind of things?
So the nice question, sir. Actually these classification are still under development. So the classification is not foolproof yet. The broad classification what we follow here is this one, sir. This one, sir. The functional is muscle tension dysphonia. It can mimic anything from here to here. And what you are saying is regarding the psychogenic. Psychogenic is diagnosis of exclusion, when we have ruled out and everything what we can rule out. And in majority of we can find out the stress factor. And just Himanshi would be more appropriate to answer your question because she just read about this what you are asking, sir.
So, sir, to make a diagnosis of functional voice disorder, first we need to rule out is an organic pathology. Once that is ruled out, then we have to look at the non-speech voice behaviors like coughing, laughing, crying, etc. So once that is normal, we can use them as a facilitator to make the patient phonate. Other than that, if there is an underlying organic pathology also, like the patient might be presenting with a small vocal polyp, and along with that he can have a functional plica ventricularis, dysphonia of plica ventricularis, because of the compensatory muscle tension dysphonia that he has developed with it. So we need to first work upon the tension of the muscles, and then maybe the organic pathology can be taken care of by ENT. Yes, also it has been stated by Aronson et al. That for functional dysphonias, speech language pathologists are well equipped to handle those cases. But still, in fact, only 2 months back, there was a patient with the psychogenic aphonia, complete aphonia, and the patient was aphonic since last 4 years, and was the only mode of communication was through writing. She was not even making an attempt to articulate also. So for that we are doing masking therapies and all the things that we could do. Even her cough, she was just doing that, I'm not able to even cough, she was saying. So there was a very deep rooted psychological trauma that she had been through, and now I've actually I referred that patient to psychiatry. So I think
Thank
there's a
you.
multidisciplinary approach that works.
Sometimes what we feel becomes problematic for us, something like pseudo seizures. When pseudo seizures are occurring, majority of the time pseudo seizures are occurring in an individual who also has a true seizure. So it becomes a little bit difficult at times for the neurologists as well as for us to differentiate what is what, because they know now what a true seizure looks like, and their behavior repertoire can actually just be like a true seizure phenomena. Look for differential kind of activities and different kind of episodes having different phenomenological gestures over there. But is there something on those same lines which could determine dysphonics?
So can you please repeat?
Repeat that question.
So when we say that there is pseudo seizures to an individual, a dissociative convulsion there, and also having a true convulsion, true epilepsy in that individual, in those individuals, the semiology of convulsions differ to a very, very light extent. And that is where both us and the neurologists go into trap. And many times patient gets treated for a long period of time with an anti-epileptic despite not requiring any, and then they develop side effects and all. Similarly, in that same line of sense, if a person also has a true dysphonic condition, a functional phonotrauma or a neurological cause there, and also a psychogenic cause there, how can one differentiate? Is there any other way to differentiate other than asking them to cough?
Is there overlap? There might be some psychogenic, there might be some organic overlap.
We look for case history, like if the stress factors can be really identified, then I think it is. There is an overlap of.
So like this muscle tension dysphonia, this is secondary to his or her stress. So what is happening, like everybody is having muscle tension dysphonia, especially in the stress scenario in which his or her laryngeal muscle can get in a spasm. This is a interplay between the laryngeal muscles and the brain. synchrony between these two things are gone. So actually there is some overlay between these, and for this purpose we have to teach them how to pronounce appropriately, and for that purpose speech and language pathologists are the specialists. And as you appreciate, the normally what we should be seeing during phonation with our endoscope is full length of it. But when the patient is having stress and muscle tension dysphonia, the size of the laryngeal aperture decreases. There is a squeeze in the supraglottic. There is a supraglottic activity. This can go from anterior to posterior. This can go from side to side also. There's many times when we are not able to see the true chord. Patient is phonating through the false chord. This is a picture to show that anterior posterior squeeze, and they can be underlying vocal fold pathology, but without that also patient can have this kind of symptom. And in this you can see the side to side squeeze. Vibration are at false chord level. You can see false chord is vibrating instead of true chord.
Apart from stroke and complete laryngeal stenosis or tracheal stenosis, there are no other causes of complete aphonia. So if we have ruled out complete laryngeal obstruction, that will present as a different scenario itself, breathing difficulty and stridor. So if we rule out complete laryngeal or tracheal stenosis and stroke by radiology, then the cause for complete aphonia is psychogenic only. Is overlap. For overlap syndrome, we have to clinically evaluate the larynx for structural anomalies. Then we have to do this speech analysis if those things are like coming along with the structural, that isn't proportionate to the structural abnormality that we see on evaluation. If they're disproportionate, then we may think that there's some concomitant psychogenic component as well. That is how we can objectify. Otherwise, we don't have something specific test for that.
Thank you, madam.
So basically we have come quite when we started like 30-40 years back, it was like we examine, we see if everything is fine, get one x-ray neck, AP lateral view, x-ray chest, everything is fine, then we say label it as a psychogenic or the functional. And usually the precedent event like some exam is approaching or something else is stressful condition. But nowadays with the specialized clinic, the equipment available as well as radiological, so we can diagnose the organic causes for those which we used to label before. I'll give typical example, bilateral abductor called palsy. We used to do cordectomy. I remember one of the child who I started doing that at around 4 or 5 years of age. Until 14-15 years of age, I've done 10 times. But nothing happens. Almost half the larynx I've removed endoscopically. But it was same. So probably it was not true sense abductor cord palsy. It might be spasmodic kind of thing. So that time you are not having laryngeal EMG to confirm that. So putting a diagnosis is important. So don't take up the cases unless the clear-cut diagnosis is there, and also need to keep the patient under follow-up. At time, as Dr. Arvind was telling, diagnosis may be something else, but over next 2 or 3 or 4 weeks, you find it was not right. So you cannot leave patient on his own. So any other comment?
Sir, wonderful job. Actually, I would like to share my experience. One of my relatives is in army. Actually, he had some contact granuloma, and he underwent multiple biopsy surgery from R&R. So 6 times. Initially, in the year of 1 year gap, then 2 to 3 years of 2 to 3 months of gap. So 6 times he underwent the surgery, and then he wanted to have second opinion from here. So we made the diagnosis of contact granuloma and gave him some steroid, advised some steroids and pantoprazole. That's all. So I thought if we are giving steroids, why not in higher dose? As I am rheumatologist, we used to give abundant amount of steroids and immunosuppression. So I used this 1 milligram per kg steroid and tapering over the period of 2 to 3 weeks. So he had complete subsidation of that chronic granuloma within a month, and now it is almost 5 6 years. He has no recurrence of that granuloma. Keeping that in that mind, another patient had same finding. He is in my hometown seeker, and I gave him steroid, and that also had relief. So this is another experience, the dysphonia with contact granuloma, and is having that no uh, recurrence of these papilloma and nodules. It can subside with the anti-inflammatory drugs. So that is another experience.
So with this comment, I thank you all. Thank you very much.